hi, Trisha. Thank you so much for being with us today. I know you've had an incredibly busy year, as we were just talking about, and an even crazier schedule. So I feel really honored that you were able to take some time to chat with me today and about this particular topic around Parkinson's and GI conditions, specifically with gastroparesis. So I'm going to assume most of our audience knows who you are, but just in case, would you mind introducing yourself and telling us a little bit more about who you are?
Of course, yeah. So I'm Trisha Pasricha. I am a neurogastroenterologist. I'm at Beth Israel Deaconess Medical Center, and I'm an assistant professor at Harvard Medical School. Some people might know me because I write the Ask a Doctor column for the Washington Post, and others might know me because I recently wrote a book called You've Been Pooping All Wrong, which has been making the rounds. But I actually spend most of my time studying Parkinson's disease, despite all of that. So I have a grant from the NIH trying to understand why some people in Parkinson's have such severe GI symptoms, why others don't, how the medications like levodopa, et cetera, will dive into all of that, affect those dynamics.
Mhm. And I know I had mentioned to you earlier that I have a particular interest in this topic because my grandfather had Parkinson's and had GI issues as well. So now that more information is coming out and just people are questioning this, like I always wondered if my GI issues were hereditary to some degree because of that. He had very similar symptoms to what I have with gastroparesis. And now looking at this a little bit deeper, I'm like, maybe there was a connection there after all. So, what is the connection, or what are you finding in your research that does start to make that connection between the two?
Yeah, the connection between GI symptoms and issues actually dates back to James Parkinson himself back in 1817. So when I went back and looked at, so he wrote these original sort of series of cases of patients that later would become called Parkinson's disease, patients with Parkinson's disease, named after James Parkinson. And he described a lot of those symptoms that we think of as Parkinson's, like tremors or difficulty with walking and movement. But in several of those cases, he also noted really, really severe constipation. And at that time, it was just noted to be incredibly profound, not responding to kind of their usual set of treatments at that time. But it wasn't until several decades later, and like actually almost 2 centuries later, that it was first really proposed in the literature. It was early 2000s that what if Parkinson's originates in places like the GI tract? What if it originates outside the brain? And the way this hypothesis is called Brock's hypothesis, named after Heiko Brock, who's the scientist who discovered it. He proposed that there was a couple of things happening. One is that cases of Parkinson's are rising. They've been rising for a long number of time. But as you mentioned, a lot of people have a genetic component and a genetic reason why they might have Parkinson's. But that risk isn't changing. Like our genetics aren't changing over time in a way that would explain why these cases are rising. And there's this hypothesis that maybe it's something in our environment that would have to account for why these cases are going up. And there's two pathways now that we think this can happen. One is through the olfactory system, which is through the nose, essentially, and it makes its way up to the brain, or through the gut. And the gut is really what I've focused on since. And we've really amassed a lot of data epidemiologically and then mechanistically about how and why this happens. But I think to just take even a big step back about why I think this feels intuitively true for a lot of my patients with Parkinson's disease is because 80+% of people with Parkinson's disease have really notable severe GI symptoms. That is the overwhelming majority. And so when even though it took a long time for the doctors, for the neurologists to get on board with this hypothesis, patients were on board with this really quickly because they live it and they experience this. And, we think that what could happen is that the hallmark of Parkinson's disease, as you might know, is this misfolded protein called alpha-synuclein. And in the brain, this misfolded protein, it misfolds, it causes other similar proteins to misfold, and it propagates and ultimately causes these neurons that produce dopamine to die. Dopamine is what's responsible in a certain part of the brain for movement, and that's why a lot of people develop tremors. But we think now that there's something in our environment that triggers alpha-synuclein to start to misfold in the gut, like decades before it reaches the brain. And then over years, maybe even decades, that alpha-synuclein misfolding propagates slowly but surely up the vagus nerve and eventually hits the brain and then starts to cause these tremors that would bring somebody to get diagnosed. But if you go through the literature, and there have been some big studies on this, people get symptoms like constipation decades before. It's actually now considered an official prodromal symptom of Parkinson's
Oh,
disease.
wow.
And we think that this is, like people get constipation, gastroparesis, which is important here. And that's considered a symptom that can predict whether you'll get Parkinson's disease. And let me also just be very careful and say, a lot of people will have constipation. All of us get constipation at some point in our lives. And even gastroparesis is a somewhat rarer condition compared to constipation, but everyone with gastroparesis certainly won't develop Parkinson's disease. However, if you have these symptoms and you start to develop other prodromal symptoms of Parkinson's, those are things like loss of smell. Those are things like acting out your dreams or acting out your nightmares, like starting to move your body. It's a kind of sleep disorder. If you start to have a number of these other things that are considered prodromal for Parkinson's, that's when your physician might say, this is forming a pattern that might put you, and especially if you may have a family member, if it runs in your family, we might think about that.
That's so interesting. I'm sitting here trying to absorb all that information, because
there's a lot. It's a long history.
It is, but it's very, I feel like, again, in your world and my world, it's talked about a lot. In our small circles, we're like, yeah, everybody knows about this. Everybody understands this. But then when I start to kind of step outside of our circles a little bit, people look at me like, what? I just heard I don't poop right? Or I have constipation issues. Does this mean I'm going to get this? And just as you noted, causation and correlation, that can happen. You can have one without the other. Sometimes they happen, one after the other. But it's just very interesting to hear these connections from my point of view, remembering what I saw my grandfather going through and just thinking about the food, the constipation issues, like the gut issues. And I'm probably going to get this wrong somehow, but I remember my mom saying something that my grandfather always had an anxious gut or a worried gut, and it was always right in his guts. And as I got into more information around gut issues for my own issues and gastroparesis, ultimately, we have set back over the years saying could he have had gastroparesis? Could that be the missing piece that maybe it wouldn't have ultimately changed anything, but it could have provided some relief in his last few years when things started getting worse. But that also leads me to ask you a question around absorption issues in the gut too, because a lot of gastroparesis patients have malabsorption, or if you take something and it sits in the gut, but it needs to make it all the way to your lower intestines to do the most absorbing. If that medication can't get to the right place in the gut of where it needs to do its absorption, what do Parkinson's patients do to get some relief for the, I'll say, more recognized Parkinson's symptoms, like you mentioned with the tremors and whatnot?
Yeah.
That was a long question. Hopefully
it was the right question. Yeah. And, gastroparesis is really common in Parkinson's disease. And there's kind of this interesting paradox, which is actually one of the things my lab is studying and lots of people looking into, which is that gastroparesis tends to both precede a diagnosis of Parkinson's. So people develop delayed gastric emptying years before they get diagnosed. But then also, somewhat paradoxically, the treatment itself for Parkinson's disease, levodopa, which is this precursor of dopamine, can aggravate that delay of gastric emptying. And something I think not a lot of people appreciate, although this group may, is that, but this is what my lab studies, is that we think about dopamine a lot in terms of what it does in the brain. It's part of your reward signaling pathway. But in the gut, it has a whole different set of roles that it plays, and it acts a little bit more like a hormone. One of the things that dopamine does in the gut is it slows down gastric emptying. And so, ironically, you have patients with Parkinson's disease who need that dopamine because there's not enough dopamine in the brain, but now they're taking the very thing which is going to slow down their gut even further, and they've already been living with delayed gastric emptying. And that's what dopamine basically does. Isn't that kind of a tricky thing? And you might be thinking okay, why? It's rough. Yeah, it is. And that's why a lot of people, my patients who take levodopa, they say, I feel way worse. Yes, my tremors get better, but I feel horrible because their nausea suddenly gets a lot worse. Now, there's a couple of things that fall into these dynamics. And one is that most people don't in fact, almost nobody today takes just levodopa, which is the precursor of dopamine hormone. Everyone takes it with something else called carbidopa. And there's lots of different ways to do that. Carbidopa, and I'll tell you why this is important. We're going to get technical, but I'll tell you why. So one of the reasons why the stomach is so important in when we're talking about levodopa pharmacokinetics for patients with Parkinson's is because your stomach expresses this enzyme that breaks down dopamine. And you don't want that to happen. You want as much of that dopamine to make its way up to the brain where your brain really needs it. That's going to help with the tremors. If your stomach breaks it down, then you're going to lose that. And it's not helping you. And so a lot of these medications like carbidopa are added on to levodopa to kind of block that enzyme that would otherwise degrade the medication that you want. What we don't know yet is who possesses these enzymes in greater quantities or smaller quantities. That's what we're looking at right now. And could it be, this is a hypothesis, but could it be that the reason people develop gastroparesis early in Parkinson's disease before the tremors is because there is this dysregulated signal between the gut and the brain saying, we don't have enough dopamine. And the gut saying, okay, let's produce more. And so your gut starts to slow down because it's producing so much dopamine. And unfortunately, dopamine doesn't cross the blood-brain barrier. So it's producing more, but it actually never reaches the brain. And this is one hypothesis for why people may develop some of these symptoms, GI symptoms, early beforehand, because it's your body trying to compensate, but just not being able to. And again, I know this is in the weeds, but dopamine, because it doesn't cross the blood-brain barrier, that's the whole reason why people don't just take dopamine as a tablet. Right? You have to take levodopa because it's levodopa that will cross the blood-brain barrier into the brain. So that's the leading hypothesis. That we don't know if that's the only reason. I think one thing we've learned about Parkinson's disease is that just like everything that we know in GI too, is that it's probably not one single pathophysiology, one single disease, right? Because there are some people who will say, and I have these patients too, who are like, I do have a little constipation, but never had nausea in my life, never had bloating in my life. Like, that's not a problem for me. Or a lot of people say, I know. Well, what does that feel like? And then a lot of people who say, like, I have the worst nausea ever, but I poop just fine. Like everyone's disease phenotype is a little bit different. And I think it's because we've only in the last 10, 20 years started to really try to unpack what's happening in the GI tract. We spent so much more time focusing on the brain. But now it's, I think, like an incredibly exciting time to be in the field because we're starting to learn about those things.
Yeah, I feel like I'm hanging on every word. I'm like, what? All of these things, like me trying to absorb all this information. But it's
a lot. I know.
It is, but it's really like you said, this is a really interesting time. I know in the last couple of years, even just for me, like I live and breathe this community, not just in like my day job, but personally because I'm part of this community. And I feel like there's been a slight acceleration in trying to get to the understanding of why things happen or where the connections are. And we're starting to see connections with gastroparesis and EDS, with POTS, with MCAS, more so with Parkinson's and long COVID and migraines. And I'm sitting here like, all of us patients, I feel like, are saying, we freaking told you so, like this entire time, right? Like our patient experience has been to some degree negated when we're saying, I feel there is a connection here. I know I have said for so long that I feel like there's something underlying that is being completely missed. What that is, I have no idea because we've never found it. Don't know what that connection is, but that there's something there that once we overturn that rock, things will start to make sense. So everything that you're saying, especially in the neuro GI space, I feel like those rocks are starting to be overturned where it's like, it might not be a complete answer, but you're like, oh, that makes sense now. Or, oh, this kind of fits what we thought. Let's investigate this a little bit further. And with the idea that we don't have, like, gastroparesis doesn't have a biomarker. Like you were saying, we don't have like a very distinct phenotype or biomarker to say this is a person with gastroparesis. I've had gastric emptying scans that are normal and some that are very not normal. Depending on the day will depend on the answer that I get, from a physician. Thankfully, I know what I have. I've had enough, like, I'll say bad of those exams to really know like what the issue is. But because we're all over the spectrum, there's no real way to like treat us, I feel like. And then when you add in the other disease states that kind of contradict, like you were talking about with dopamine, I did not know that. So it makes treating the
Right.
gastroparesis and treating the Parkinson's that much more difficult. Or, just thinking about like idiopathic gastroparesis, somebody who doesn't have any idea why they have what they have, it makes treating all of us so differently. We don't have one treatment that fits us all. We barely have anything that fits any of us, right? So it's
Yeah.
such a, I don't even know a word to describe the situation I feel like that we're in, because it feels very hopeful, but we also, because of how research works, I know that we're still so far away. But I see hope on the horizon now, at least with
Yeah.
a new interest, new studies happening, people like yourself who are like, I think this kind of like makes sense here. I'd like to investigate it. And hopefully, the next couple generations coming up with this diagnosis will have better treatment options than we have had in the past. That would be wonderful.
I think you're absolutely right. First, right about how frustrating this whole process has been, and how hard it's been to pin down a good test that it reliably
Mhm.
captures what is wrong. And I think the underlying issue is the same that we're seeing in Parkinson's, which is that in gastroparesis, there's not one thing wrong in every single
Yep.
person, right? Wrong is not even the right word, but um, I think I was encouraged by, I almost wonder if we were in the same room. There was a nice presentation at DDW this year where the Mayo Group was showing some biomarkers that they've been
Mhm.
looking at for gastroparesis. And I like that type of study that's like completely independent of the gastric emptying, because I think we all agree that that's
It's
fraught.
not the best.
For like, so everything you've described happens to everyone. It flips back and forth. But I think the fact that they're homing in on biomarkers, and those are
Yes.
biomarkers that they've identified are sharing some common pathways. A lot of it is due to inflammation, and
Mhm.
inflammation is like become a bit of a buzzword out there in social media, but there is actually a lot of good and real science behind it. And I think if we start to target this based on what we're finding as the biomarkers, I mean, that's also, I will say, the hope in Parkinson's disease too, is we're not there yet, but what we want to do is to say, if we have this window of time where you get GI symptoms before it hits the brain, wouldn't it be great if we could capture a biomarker in the gut
Yes.
that tells us who is somebody who's at higher risk of ultimately maybe developing Parkinson's or who's not? And then how can we maybe change that trajectory a little bit? So
Mhm.
we're working on that. One thing that I think, it's true that like when I bring up the idea that dopamine plays this role of delaying gastric emptying, a lot of people are like, I didn't know that. Like we all
Yeah,
think of
I
dopamine
didn't.
as like a reward. But if you think about it, one of the mainstays of medicine, the only FDA-approved medication for gastroparesis is metoclopramide or Reglan. And what is
Mhm.
that? It's a dopamine antagonist. Well, that's the reason that it works. It blocks
Yeah.
dopamine. Now, I will say in Parkinson's, and you asked at the very beginning, like, what can people do? So I want to make sure I get
Mhm.
to that. Is that, well, in Parkinson's, we actually don't want to give anybody anything that blocks dopamine. And this is like sort of a little bit of the paradox and the problem that we live in, because if we block dopamine, yeah, their GI symptoms can get better, and then we just suddenly make them super rigid and we make the tremors worse, and that's a horrible experience. The good news is that we have a couple of ways, though, that we can help people that are a little bit different than other people with gastroparesis. One thing that I always do in somebody who comes to me with Parkinson's and gastroparesis, and honestly, this is probably something we should do for anybody, regardless of Parkinson's, but who has these GI symptoms, is I check for H. pylori. Helicobacter
Mhm.
pylori, which is this bug that lives in the stomach. I'm sure, a lot of people in this community have gotten tested for that and maybe even treated for it before. The
Yeah.
reason in Parkinson's it's so helpful is because H. pylori seems to express this enzyme on the outside of its shell that also can interfere with the absorption of levodopa. And so they've done these studies where if you eradicate the H. pylori, which is relatively simple, 2 weeks of antibiotics, then suddenly they're able to absorb that levodopa, it makes it to the brain, the nausea can get a little bit better. So I always check for that. That's helpful. And then the
Mhm.
other thing, which is also like kind of another diagnosis, which is like a whole separate podcast, is SIBO. But I check for SIBO
Yeah.
in my Parkinson's patients. And the reason for that in this population is certainly one, because they often have bloating. They often may have diarrhea or symptoms related to the SIBO itself, but because a lot of the bacteria that we think overgrow in SIBO, in Parkinson's, those bacteria can break down the levodopa and can cause trouble with absorption. So
Oh,
when we treat the
interesting.
SIBO, sometimes, and this is like some small studies that were done in the last decade, sometimes even treating the SIBO, even if you don't have necessarily a lot of bloating or diarrhea, just treating it can make your motor symptoms get better. Isn't that wild? Because you're just helping the
That's
improvement in.
crazy.
Yeah.
That's crazy.
It's like, I mean, but it's also like incredible how closely these things are connected. And these are studies that have only come out in the last 5 to 10 years. So those two things I always look for, even though we don't want to prescribe something like metoclopramide for our Parkinson's patients. We do have other anti-nausea medicines that we could consider. As you know, as the community knows, domperidone used to be an option for a while, and actually that doesn't cross the blood-brain barrier. So for Parkinson's, that was a really nice choice. It's no longer an option here in this country, but that used to be one that sort of checked all the boxes.
Yeah, I think probably anyone in our community will be nodding their head to that to say, yeah, we missed that medication too. That was really
I know.
helpful. But hope on the horizon for replacement.
Yeah.
But it really, like, thinking about everything that you're mentioning, like SIBO and everything else, like I had a G-POM done back in 2018, and I was
Okay.
very successful with it. I actually, once I healed and inflammation went down and I started
Yeah.
feeling better, there were days years ago that I like forgot that I had gastroparesis because I was
Wow.
completely normal all day. And,
Wow.
I wasn't eating, really heavy, like greens or raw vegetables. I haven't touched beef in I don't know how long, probably never will again.
Yeah.
Because there are some things that I still didn't tolerate, but I was doing okay. And as the years have gone on, my symptoms have started to come back even more. And a lot of that is because of recurrent SIBO, because as I
Ah.
understand it, my small intestines are doing more work than they were ever intended to do. And that leaves me at risk for SIBO, which causes issues with motility. And as I dug into that a little bit further and seeing more people in the community asking questions about SIBO, wondering like, well, I have these symptoms. Like, what am I flaring today? Is it recurrent SIBO? Is it gastroparesis? Is it this?
Right.
Is it that? Am I just so constipated that my downstream issues are causing upstream issues?
Yeah.
And what do I do? And, as a physician, someone like myself coming to you, like, I know that I'm an overwhelming patient. Totally get it, because it's what comes first, the chicken or the egg. What do I treat
Yeah.
first? Where do I look first? All of these things are just contradicting each other, talking about treating the Parkinson's while also treating the gastroparesis, possibly treating the SIBO, but it might be recurrent. It's like, what the heck do we do? How do we do
Yeah.
anything? And it really sounds like it comes back to, again, more research and understanding,
Yeah.
what actually does come first and what works to help motility here, and does it rebound in the right way to help motility here? If we can fix the constipation issues, does that help the stomach? Because I know
Yeah.
once I finally am able to use the bathroom, I'm hungry again. It's
Yeah.
I understand why, but it's the weirdest physical feeling to not be able to go to the bathroom for about like 5 days, and you're finally able to go. And I'm like, oh, that's what hunger feels like again. Like my
Ugh.
body and my brain feel physically hungry. And then I want to eat everything, and I go through that cycle all over again because I'm like, well, this is no way to live, So when you add the
Yeah.
additional issues on top of it, the other chronic illnesses on top of it, you add the
Yeah.
fatigue, you add the additional maybe autoimmune issues, the migraines, any level of inflammation in the body, we're just like, what the heck are we supposed to do? And there's no
Yeah.
real answer, which is, I think, for us and for anyone like yourself too, who's in research or treating patients, that's what's so frustrating, is not having that specific, reasoning, that specific marker, that specific medication to understand why this is happening to you. And it's kind of a guessing game to figure out what works. And you have to treat
Yeah.
one before the other. And you're just like, I'm tired. I'm tired.
Yeah. I think from a patient standpoint, it's miserable. I think
Mm-hmm.
from the best advice I could give, and this is not easy advice at all, is to find someone who is a specialist in motility or a neuro GI.
Mm-hmm.
Because from our standpoint, you know, what you described is what we see every day. It's not like, you know,
Yeah.
like you were like, I know I'm like a complicated patient. It is complicated, but it's also what we see, you know, like it's like what
Yeah.
we are proud to see and happy to see. And, but the flip side of this is also true in that like, it's frustrating to be a clinician and to say, I don't have the biomarker that's going to tell me the exact pathophysiology wrong in your case. But what I
Hmm.
do know is that one is something wrong. So let's validate that. And that we have a lot more treatments, I think, than sometimes people who've only seen community physicians have
Yes.
experienced or appreciated, you know,
Hmm.
I think that's, and again, this community is really engaged and locked in, but you know, sometimes people will know of Reglan, of metoclopramide, they'll have tried that, and when that doesn't work, it's like, well, we don't know, there's nothing else approved. But that's not,
Yeah.
I mean, you know, Reglan's like not even necessarily the first thing I would prescribe, but you know, we
Hmm.
have a dozen other things. It takes developing a good relationship with that doctor, trusting that doctor trusting you, most importantly, and
Hmm.
then going through the trial and error, because that is what it is. We kind of make our best guess at what we think is
Hmm.
going to help, at what's originating. And if it works, that's wonderful. If it doesn't work, we just go down the line. But the point is to stick with that person and stick with the treatment plan until you find what works. But it is,
Yeah.
I mean, I hope in the next couple of years, we start to shift the needle more towards why don't we first understand what's going on and then treat rather than treat? And then when you respond to something,
Hmm.
say, oh, that's what it was. Like maybe that was the issue
Yeah.
the whole time.
Yeah. And I think like I love the additional conversations that we've been having, you know, really recognizing the gut brain interaction with some of these issues. And it's hard though, because what we see a lot of times in our community, and you said like for community gastroenterologists, somebody who might not be focused on motility or focused on research and really staying up to date with that, doesn't necessarily understand the interaction and the relationship the way that you do. So when someone like myself who lives in a rural area, you know, we go to the
Yeah.
physician, we know that something is wrong, and they're like, again, well, Reglan didn't work, so I have nothing for you. And
Right.
then it can sometimes potentially lead to the harmful it's all in your head conversation. And I think
Yeah.
that there needs to be more motility. There needs to be more, neuro GI physicians out there. But I'm hopeful that the louder we all are, the more conversations that we have, the more that we can
Yeah.
kind of change that narrative to where everybody understands what you're talking about. Everything that you said to me today, like, I'm like, it makes sense. I feel smart. I understood that. But
Yeah.
when I hear that, I hear what you're saying, and I understand that there is science behind it and that there is the pathophysiology of what is happening behind the scenes that an average patient is not going to understand. I get that. But when you don't have someone like yourself to explain it so eloquently, and you don't
Yeah.
necessarily have a physician that is up to date on the latest research, it leaves so many of us stuck. Or we see the physicians that we want, or we know the physicians that we want to see, but their waiting lists are forever. So
Yeah.
it's part of
That's a
our
real problem.
responsibility as an organization where we want to have these conversations openly to at least arm the patients with this information. So someone sitting here might be listening and think, oh my gosh, maybe I should see a neuro GI. Maybe these have been some neuro symptoms that I didn't understand what was happening, and neither did my
Yeah.
GI, or vice versa, where they might know that they have Parkinson's, but not really understand the GI issues and not really understanding like why the medications aren't working, when it really comes down to it's your gut. And to work together
Yeah.
to say, I need a better medical team. I need us all to communicate. I need us all to have the conversation, because that is in all reality what's missing, is the understanding, the communication, and all the things that you were saying, where I'm like, I just want to replicate you and your energy to have these conversations with everybody.
I know. I think part of where we've dropped the ball, not through necessarily a fault of our own, but like we haven't gotten the message out well, I think, in
Yeah.
the last, 5 to 10 years or so about all the progress we've made in
Hmm.
diagnosis, in treatment, and it's not even reached people within our own GI
Yeah.
provider community, right? And I
Hmm.
find that frustrating. I mean, so most of my patients are actually patients with Parkinson's disease now, because that is my research focus. And there are not too many GI doctors who focus on Parkinson's disease. There are a couple, but I find sometimes if you can even meet me one time, you don't necessarily have to like establish care. Like a lot of people come from out of town, but sometimes just meeting somebody, and this is true for people with gastroparesis who have never met a neuro GI doctor, you can get a one-time visit to kind of spark the conversation, get a lot of ideas written down. Then that can maybe be helpful because you can take that note and take those ideas back to your local doctor. And so I often find that like I have a lot of patients who come in, we haven't really even talked about constipation and Parkinson's, but that's like a huge thing. And they just won't have, considered a lot of the things that I consider in that population. And I don't have to do it all myself. We don't have to do that all together. I can just give those instructions and ideas back to them that they can take to their doctor who, can then go through them systematically one by one.
Yeah, that's really helpful, which I do want to ask around constipation issues. Are there specific, like I take Motegrity. I've talked about it a lot. It's a drug that has been very helpful for me. Is that something with Parkinson's, like a drug that you might help with constipation, or does that interact with some of the Parkinson's medications as well? As you were explaining before, since Motegrity is different than the average laxative, it's not comparative to Miralax and some of the other, constipation medications out there.
Yeah, Motegrity or prucalopride is a great medicine. Actually, we use it in Parkinson's patients a lot, and it works really well. The nice thing about, for people who are less familiar with prucalopride, which is Motegrity, what's nice about it is that it acts on these serotonin receptors, which are throughout your GI tract. So it can help with gastroparesis. There were some big trials that came out about that now, like, within the last 5-ish years ago, and with constipation. And then you often see both in Parkinson's disease. So it's a really nice medication, as opposed to, there's some other ones that we talk a lot about when we talk about constipation, like linaclotide or Linzess, which is a fantastic medicine. Really won't help too much with your nausea, with the upper GI symptoms, unless some percent of that is being driven by your constipation. And it is true that about 30% of people who have these like very severe lower GI issues like constipation, those will manifest as nausea. It'll manifest as the upper GI symptom. Just like you've said, it's sometimes hard to know what is driving what. So I use prucalopride a lot. I also do use all of the ones that you might think of. Linzess, I use Amitiza, which is lubiprostone. One thing which is really underappreciated in Parkinson's disease specifically is pelvic floor dysfunction. It affects patients with Parkinson's at a much higher rate than the average population. And even in the average population, we are not diagnosing this as often as we should. It's a little bit of an underappreciated diagnosis, but an underappreciated cause of constipation and bloating. Bloating is a huge problem in Parkinson's disease. People really they have pain and bloating. Sometimes it's hard to understand, is the pain being driven by the constipation? Is it being driven by the stomach? Like, where's the pain coming from? And it's funny that like the pain and the bloating sometimes get better when you treat pelvic floor dysfunction. It's an underappreciated cause. So when somebody comes to me with constipation and Parkinson's disease, I think about all of these medicines. What have they tried? What has not worked? But I almost always, by the time they're seeing me, it'll be time to get an evaluation for pelvic floor dysfunction and check for that, because it's something like 60% of patients with Parkinson's disease have it. And that's like a really high number for something that it's so high compared to, like everything else that we have in medicine. Pelvic floor dyssynergia can be really nicely treated without medication. You treat it with biofeedback, physical therapy. And so if we can catch that, I almost consider that good news, because I can say to someone like, look, we found this thing that we can fix in about 2 or 3 months with PT. Now, finding a PT who does biofeedback therapy, that's a challenge in and of itself. I'll give like everyone that. You can be, the wait list can be really long, but once you get in, it's like upward of 80% of people find a lot of relief with physical therapy alone. So it's, in a way, I think of it as almost good news.
Yeah, I'm actually really glad you mentioned that. I just started going back to pelvic floor therapy, and I know I did it a few years ago, and after I think it was a good couple months in, I was like, I feel like I know how to poop again. Like, I feel like, again, I've been pooping all wrong, this entire time. And I'm like, what magic did you do in here to make this work, and it didn't work perfectly, but I'm like, this has been a huge improvement in bladder issues, in my stomach,
Yeah.
in actually being able to go to the bathroom and being able to learn control of the pelvic floor
Yeah.
muscles. And I actually went back again after my hysterectomy as well, because, they mess everything up in there when they do
Yeah.
that surgery. So you have to go back in after that. And I just started going again because I'm like you said, there's no medication involved. I'm lucky enough to go to somebody that my old PT recommended. So I feel pretty
Oh,
good. I'm like,
great.
she was really good. So I got pretty lucky in that way. But it really is such an underappreciated way to
Yeah.
feel better. But like you mentioned, just like a motility specialist or a neuro GI can be exactly what you need. Sometimes it's the access and the wait list that really can set
Yeah.
somebody back, where they hear, oh, it'll be like 4 or 5 months until you get in. It's like,
Yeah.
that's not great, but I can handle that. And then you try somewhere else and they're like, it's a couple years. You're like, but
Oh my gosh.
I need help now. Like, what are you supposed to do? So I think, we have all of these things that can help, and you're not going to have the answer. I certainly don't have the answer. We just need more people, of getting
Yeah.
the access to these treatments easier and more affordable for people. I found like my insurance doesn't even cover that. So I have to pay out of pocket for it, and
Oh my
I'm
God.
fortunate enough that I'm able to do that right now, but not everybody is. And then it goes into the access issue. So it's difficult. And with all of the compounded issues that we all have, and all that you need to see a specialist for this, a specialist for that, a specialist for the mix of this and this medication, this type of therapy, it gets very overwhelming. So to have somebody and to have a team that can work together to really say, let's look at this holistically and where can we start? This
Yeah.
person works here, this person works here, and hopefully they all talk to each other would be a
That's
wonderful
the
thing.
that's the ideal. I know. I think we need to take the American system and start from scratch almost. The other issue, speaking of barriers, that um, it's often can be difficult to find a pelvic floor physical therapist who will work with men, unfortunately.
Yep.
And I think there's this misconception out there that pelvic floor dysfunction is a female problem. It's not. And especially not
Hmm.
if we're talking about Parkinson's disease. It affects men just as commonly, which is why we check for it in our male population too. And but some physical therapists, I think it's an extra level of training to work with men that some just don't have that. So I know that
Hmm.
our male patients have a little bit more trouble getting in, but once you're in, it's like you said, it can really like turn the game around. And I sometimes describe it to people as like, we've tried all these different medicines. They're not working, right? And ultimately when you're on your third or fourth laxative and it doesn't work, we have to ask the question of, are we addressing the wrong problem? Like maybe there is a
Yeah.
little bit of issues with the motility part of it that's almost always there in Parkinson's,
Hmm.
but sometimes when you fix the pelvic floor, it's like suddenly like the dam has burst and all those laxatives suddenly work really, really well, and it's
Yeah.
like, wait, we actually never needed 3 laxatives. We just needed to like open the door a little bit.
Hmm. Really, there's nothing better than feeling the relief from going to the
Yeah.
bathroom. And, I say that like mentally and physically. And for someone
Yeah.
like myself, I constipation issues predate gastroparesis for me. I know I said this early on,
Oh
I think
no.
last year in the podcast, where I'm like, my mom was like, you were never a good pooper. And I'm like, cool. I've now told the internet that multiple times, but here we are. Um, and I think about my entire life that's always been a problem. And I was thinking about this a couple days ago before
Yeah.
we were going to record, and I'm like, it wasn't until I was diagnosed with gastroparesis that they started to address the constipation issues. And,
Hmm.
like, you don't want to play a what if game. You don't want to like say, well, if they had, maybe I wouldn't. You don't want to live in that space. But it does make me wonder, like, why wasn't that taken a little bit more seriously? Like, I
Yeah.
know this has been an issue my entire life, and it only got worse when you added the actual, upstream GI issues.
Yeah.
And now would they all affect each other? There are some days where it's been a very, very long time. I am trying to eat. I now can't eat anymore because I'm literally full. And then you go to the
Yeah.
bathroom, like, I need to go take a nap. I need to lay down. I feel horrible for a little while. And it's like that
Oh,
cycle just keeps repeating itself. And I know I'm not alone in this. And I know that there are a
no.
lot of other people that feel this too. So, it's really good that we can kind of step back and say, all right, how do we address this issue? And they are connected. Nobody wants to eat when you are completely full. And you don't want to eat when your stomach is bloated. It's hard. You have to go to the bathroom. You can't do it. The medications are causing these other symptoms. You're feeling all this stuff. It's just
Right.
messy. It's just messy. So again, with pelvic floor therapy or something like that, if that can provide even like 1% relief to start and just get you moving physically, literally in the right
Yes.
direction, it really can be so helpful and have an effect in a positive way for once of all the other things starting to fall in place, like you mentioned with the laxatives. Would just open the door a little bit and now you're starting to feel some relief, and maybe some other medications will start working, or an even
Yeah.
better way, maybe you can be deprescribed from some of your medications because now
Yeah.
something else has happened and you're not putting all of those medications in your stomach that are just getting harder and harder to absorb and giving. I don't know if this is scientific or not, but my brain's like, less meds, like I have a better chance of absorbing the ones I really need to absorb if there's less in there. So, it always
Yeah.
comes back to pooping. And it's not just because we're talking. It just always comes back to
Jess, isn't
pooping.
that true? But I think you've hit on something that's so common to people, which is that they take medicines to help them poop, and those medicines can be really harsh and make you
Yeah.
feel so uncomfortable. And sometimes you're like, like the stimulant laxative, like Senna, for example. Sometimes you're like, was the amount of discomfort this caused even worth it? Because it's so uncomfortable.
Yeah.
And it is not uncommon that we hear after physical therapy, suddenly it's like, like imagine, this is the analogy I always use. Imagine trying to squeeze toothpaste out of a toothpaste tube, but the cap is on. And that's what you've been doing this whole time. And you're putting this Senna
Mhm.
in. And of course, it's causing really painful contractions because nothing can come out the other end. When you take that off,
Yep.
sometimes those laxatives don't feel as horrible anymore. And as you said, the best case scenario is that we say, you actually didn't even need that many. You might need one.
Yeah.
You might need an occasional thing, but maybe you didn't need to be as aggressive as we thought.
Yeah, that's really important. And I think that there was so much information that you gave and in such a way to understand it. And I think that no matter where you are, like in your gastroparesis journey, also your constipation journey, or, familiarity with Parkinson's and these connections and just neuro GI, that there's something that anyone can take away from this. Even if you don't have chronic GI issues, but just someone who struggles with occasional constipation, it's an easier way to understand what's happening in your body. And I think that that's just really important to share, and why I continuously love to have these conversations, because they're educational, but they're understandable for our population. It's validating to hear from an
Yeah.
expert, a researcher, a physician, to say, like, I hear you. I see that this is a problem. I can literally understand what you're going through, and here are some ways that might be able to treat it. Or, hey, I heard this conversation with a physician. I learned these things. You bring that back to your doctor and say, can I get that one consult? Can we set that up? Can we do that to get me in the next step of what I need to do, and just kind of go from there? So hopefully this feels empowering to people, and, just really be able to take something away from it. And just thank you so much. This was so great to chat with you, and so much good information. Like I said early on, I don't know if we were recording yet or not, but there's no TMI here. So I'm just love being with my people, to be free to talk about all of the awkward things, because they're no longer awkward.
They're no longer awkward. We are proud. We're poop maxers.
Yes.
We're not ashamed of it.
Yeah.
But thank you for having me. This is a wonderful thing you're doing for the community. And
Thank you.
there's a lot to learn. I mean, that's the joy and excitement of being a researcher, but there's also a lot we already know, and a lot
Yeah.
that we just need to do a better job communicating. So I hope people, as you said, I hope people leave with a little bit of optimism about what they might do next.
Yeah, I think so. Thank you so much.
Thank you.